is the Senior Clinical Director at Treehouse Eyes, Virginia in the US. He's currently the co-medical editor for the review of myopia management. Dr. Kevin Chan is also a TEDx talk person, and he has had several positions in Johnson & Johnson and Essilor in the past. He's currently the vice chair for the Myopia Special Interest Group for the American Academy, where he's also a member of the Communications Committee. Dr. Kevin Chan has distinguished himself in terms of myopia management clinically, in terms of myopia management research, in contact lens, orthokeratology, and giving guidelines internationally as well. Dr. Kevin Chan has authored several publications, and we're glad to have you. So Dr. Kevin Chan will be talking to us about myopia management and how to present it to parents to get them involved. Thank you very much.
Thank you so much, Dr. Obi-Wan. And also thank you, Ivrica, and for inviting me to join this insightful webinar. And in celebration of the Myopia Awareness Week, I'm sure many of you are excited and also bring your mission and your vision to your clinic and share with your patient. So again, my name is Kevin Chan. I am hoping to bring some perspective from the North America aspect. I'm currently based in the state, and so I hope that I will be able to, I learn a lot, through this first half an hour from Dr. Osuwan. And so I hope that I can bring a different perspective about speaking of how to communicate with patient and also with parent about myopia management. So again, I'm really honored to be here to celebrate and support the global initiative of Myopia Awareness Week. And I believe this is the second day. I'm sure many of you are, so excited for joining for the rest of the webinar for the following week. And as you know, there's plenty of content that will be covered. But for the sake of this particular webinar, I'll be focusing on our artistic aspect of presenting myopia case for a parent. Here are the financial disclosure, but I have no particular conflict of interest pertaining to this particular presentation. So many of you are doing myopia management, for which I'm really glad and appreciative, because we all understand that, this is a really global burden for many of our patients. And we all, as a clinician, we understand what myopia is. We all understand the definition, and we know how to present to the patient, on a service. But how can we learn more about from a parental perspective? Because myopia, even though it sounds very simple, very intuitive for us as a clinician, honestly, many patient and parent are still, very confused about myopia and what it means, to the child. Go back to the basics. Definition of myopia, obviously, like they have been interrelated to the definition of nearsightedness. However, when you look at the definition of each terminology, there's actually some nuanced differences. Nearsightedness is actually the symptoms of the refractive error, generated by myopia. And the definition of myopia is actually more physiological, specifically looking into the ocular elongation that is faster than expected. So meaning, when your eyes is getting longer and longer in size, the focal point is no longer be able to catch up. So that's why I usually tell the patient that it's not about you have nearsightedness. It's more about how your eyeball is physically growing faster, more than what we normally would expect. So that is something would actually catch the attention about, oh, it's not just about nearsightedness. It's something else. Okay, let's hear more about that. So that is the first hook I would like to bring, to the clinician that, we need to first figure out how to define myopia to our patient first. Otherwise, you will easily lose track of what they're thinking about myopia first place. And second is about learning about and try to understand the causes of myopia. And obviously, we all know that myopia is a multifactorial disease, including genetic predisposition and also combined with environmental influences. Later on, we're going to talk more about environmental impacts, for myopia. And as I mentioned earlier, the symptoms of myopia is known as the nearsightedness. And when you have nearsightedness, including myself, I'm a -5 myope. And when I wake up in the morning, I barely can see, the alarm clock. So I know that at first by firsthand, I experience a lot of daily challenges and difficulty seeing at far distance. And also I cannot really play sport the way I hope it to be. So I'm currently wearing lenses, and that will help me with, daily work and activities. But imagine, when you have, someone as young as 6 or 7 years old, they don't even understand what a normal vision is. So it's just really hard to engage with them if you don't even, have the interaction with the patient, have shared a common background with them. So really emphasize the fact that, myopia really causes a myriad of symptoms, including quality of life decline, as Dr. Oswan have mentioned earlier, causing a lot of mental health burden and anxiety level. And I see it from day to day as well. And as we come to the notion of, um, different causes and risk factor for myopia, I'm not going to elaborate any further because it's really well known, and that's not also not the focus of this presentation. But I'll just really briefly point out three different, bullet point here. The first is genetic predisposition. That is something we cannot change, and used to be thought as the predominant factor. However, more and more studies have found that there's a lot of interplay, interaction between genetics and environmental influence. That is a specific core subject known as the epigenetics. And there's still a lot that we don't know about the interaction between these two, factors. But number of study actually, recent study published in Arvel recently, about a month ago, and Dr. Paul Gifford actually did a really good talk for his poster about how the prolonged new work actually have impact more than just spending more time outside. And even though both particular factor are equally important, but more and more study have found that, neo work actually play a bigger role compared to, the time being spent outside. Another interesting finding is that even when you encourage patients going outside and spend more time playing outdoor, and study have found that the light intensity is actually not as critical or not as important as we initially thought. It's more about the duration of how much they spend outdoor time. That's the key factors for mitigating myopia progression. So here's something that I usually bring to patients' attention about what to look out for. Even if they're coming in, for initial consultation, they may not have a clear understanding or idea, what the child is experiencing. For example, if a kid are diagnosed with a -2 diopter myopia, and as a parent who are not yet or not being myopic, chances are either mom or dad doesn't even understand what -2 will elicit. So I usually put a little free trial frame onto the parents' eyes, like a +2 diopter trial frame, to help them understand what your child as a -2 is experiencing in school and in daily life. So help them understand the really, the core symptoms of myopia, including a laundry list of like, you all understand, blurry vision at distance, and patient along with astigmatism can also make the vision even more distorted. And at the daily work and activities, in school, they will have a lot of struggle with distance object. They frequently squint, to compensate. And as a result, they also have a lot of headache, symptoms, headache, and eye strain at the end of the day. So it's really important to emphasize the merit of why we need to do annual eye exam for every single child as young as 6 years old, according to the American Optometric Association guideline. And not just about, checking the visual acuity, but also need to include a merit of assessment, including ocular motor evaluation, binocular vision assessment. And obviously you have to check the refraction using rhinoscopy and very importantly, psychoplegia. Okay, later on, we're going to talk about this particular aspect for myopia management. And obviously, we have to evaluate the retina, make sure everything is all clear and remarkable before initiate any type of treatment going forward. So everyone understands the importance of why we have to care about myopia so much, because myopia is a reversible disease that we have to intervene very early. And according to number of study that found that I want to point out this particular study showing that there's a direct correlation or association between the axial length elongation and the risk of developing visual impairment. Specifically, when a child develop an eyeball with an axial length between 24 to 26 millimeter, the chance of developing that type of visual impairment is about 40%. But as you can see, it has been escalate exponentially. It's not going in a one-to-one ratio. By the time the kid actually, develop over time from a kid to become an adolescent to a young adult, the chance of staying with the same axial length is very, very rare. So in my experience, a lot of teenager or even young adult have actually progressed up to 30 millimeter in size. So you can see the risk is substantially higher compared to when they first started with myopia management. So it's really, really critical for you to understand that by emphasizing the fact that this is not just about the refractive error problem, it's also about the abnormal physiological disturbance in the eye. Many of you understand and recognize the sequelae or the ocular consequences resulting from myopia. I'm not going to elaborate much further, but one thing to keep in mind is that I usually focus on what can be done, to minimize any chance of developing that type of eye disease. You are familiar with something called a myopic tractional maculopathy, which is shown on the fundus photo on the right-hand side. But this is not just it's a mean for me to help them understand what can possibly happen. It doesn't necessarily mean that that would happen in a child. So it's really important for you to understand and present it to the patient that this is just something that we need to be aware and we want to prevent this from happening at all costs. But one thing I learned in my daily clinical experience is that try to avoid scary tactics. When you presented them that a lot of charts, a lot of diagrams showing, what the risk of retinal detachment, these are the percentage that you have to be watch out for. Yeah, those are critical information for us as a clinician to understand. However, I understand that sclerotic tactic is really poorly perceived, by patient. Either you just scare the patient away, or you really, increase the level of anxiety and the unnecessary burden for a patient and the parent to undergo. So really understand that, it's just a mean for you to help them understand, but it is not, translated to the ultimate outcome for them. So as I mentioned earlier, the early intervention we can present it to the patient, the better it would be because myopia is something that it's a one-way street. Once it's take off, the train is going to accelerate very quickly. So the early, the better. So one thing to keep in mind that according to the World Council of Optometry, they have initially three M's. This is a 3M pillar known as the mitigation, measurement, as well as management. So for the sake of time, we cannot really elaborate further. But really understand that we need to present it to the patient in a very systematic manner, including how to measure axial length appropriately, how to present them with a multifactorial manner, including lifestyle, diet, exercising, as well as the proper eye examination. And all these things collectively can help promote better eye health in the long run. And this is something that I truly believe it in heart, because proactive intervention is key for every myopic child. Whenever you see someone who are not yet myopic, chances are they will become myopic at some point. So you need to really grasp the best window for treating those kids, the early, the better. And obviously, as we all know, just like many other different clinical aspect in medicine, prevention is always better and easier than management. So by the time you start managing, it will take a lot more time and effort to achieve the same outcome. In fact, the outcome may not even be better, than someone who can, actually prevent myopia from happening in first place. Something that, Dr. Levi have mentioned earlier is that, simply prescribing a pair of glasses is really good. It's a good starting point, but it's not replacing the need of myopia management. In fact, a lot of clinicians still believe that, under correction can be conducive, or actually beneficial for slowing down myopia progression. It is actually not true. Whenever you undercorrect a patient, chances are, you actually accelerate the progression over time. So obviously we want to ensure that, by, mitigating myopia progression, we're able to help improve the quality of life for those patients because they have a long road ahead, including social life, daily life, academic life. So altogether, we want to do something to proactively encourage, myopia management for all clinicians. And another aspect, as I mentioned earlier, is about the environmental influences. Many studies have found that, spending time outdoor is really beneficial for young kids, especially a lot of kids in Asia, particularly in China and Singapore and Taiwan. Those countries have over 90%, of the population or having the young kid already been diagnosed with myopia. So you can see how prevalent the problem is globally. So specifically, when you encourage kids to spend more outdoor time, you actually help, increase or regulate the dopamine uptake. And a number of studies have found that there's a direct correlation between the outdoor time spent and the level of intensity that myopia can progress over time. On the other hand, depends on the geography and seasonality. Many patients may not be able to spend enough out time, like particularly in North America. So a lot of time patients complain about eye strain and headache, or just cannot really stay focused long enough. Their attention span is just getting shorter and shorter. So these are the things that we need to encourage the patient how to do better. And we're not here to take away the screen time from them. We want to encourage them to regulate the screen time and outdoor time in a really, balanced manner. As I mentioned earlier, the importance of eye examination cannot be underscored any further. Whenever you have someone coming in, not being myopic or not having any complaint, being asymptomatic. So it doesn't necessarily mean that those patients are symptom-free. They just don't know how to express, what they're going through. Like what I said earlier, if you don't even know what a normal vision is, it's hard for them to really appreciate what a blurry vision would feel like. So really, so something we have to be cognizant about, how about differentiation between pre-myopic patient and those who are having existing diagnosis of myopia. Because most of the time, pre-myop patient tend to have a very good skill or good mimicker. They actually can help accommodate really quickly to just to fool you. Oh, I'm seeing 20/20, but it doesn't mean that patient is being hyperopic or simply safe enough to not to pursue any treatment. I'm not going to go through a bunch of the treatment modality for myopia because I know there are many upcoming speaker that will be presenting for this particular topic. But one thing that I want to pay attention to is the spectacle part because a lot of times clinician doesn't want to prescribe spectacle, because many believe, or at least from a patient perspective, glasses can actually accelerate myopia progression, which is obviously untrue. We want to, whenever you make a first diagnosis, you do want to make sure you can prescribe a pair of single vision glasses at the very minimum. This is the first time diagnosis. It is something that is critical for a patient to understand. If you don't have your glasses on, okay, chances are your child cannot really see well, and it would directly impact the social and quality of life. So that is the first thing that we want them to understand. Glasses is nothing, it's not your nemesis. It's something that will truly help your child to succeed and develop normally. Obviously, it's a good starting point, but it doesn't help replace the need of different strategy of myopia management. One of my passion is about orthokeratology. I do it on a day-to-day basis. As we all know, ortho-K is something that is non-surgical and also reversible treatment method to reshape the cornea in order to help correct the vision during the day, but also have a good benefit to slow down or mitigate the axial length elongation. And study have found that, by using ortho-K, many patients with poor quality of life can be much improved because they feel like they have better self-esteem, better self-confidence. They can, present themselves in school and daily life in a much better fashion. So really, pay attention to how many treatment modality is available for your patient, and depends on your clinic or geography. Not every clinic can provide ortho K, extensively. That's all right, but at least give them an option to think about. Okay, there's something out there. I'll be happy to send you to a different provider who provide ortho K service for your child. And really prioritize, ortho K is more to do with just vision correction. Rather, it's just a therapeutic intervention for your child. By doing ortho K, you're not just correcting the vision, but also prepare them, have a better future in the long run. So obviously, we want to emphasize the fact that it's something very similar to like having a dental retainer or, Invisalign, and something that patient can easily relate it to. Ortho is not something that many clinicians are aware or actually comfortable talking about, but something that you have to be aware and be prepared to present it to your patient. Another aspect is about multifocal lenses. I usually try to make it fun, and it's not something that, patient cannot learn. I have patients as young as 5 or 6 years old wearing soft lenses successfully, and they can even do it independently all by themselves. And most of the time, patient or even the parent are so surprised how much the kid can handle and can achieve. So really, whenever I start with the initial training for a patient, I will initiate or encourage patient to work with the patient rather than working for the patient. The difference is that when we work with the patient, have them, guide them how to put the lenses on in and out, independently, it's actually going to help them build the rapport and the independence, rather than just doing it for them. If you do it for them, patient cannot really appreciate why we're doing what we do. So really understand that, as young as 5 or 6 years old, those patients can still, independently, putting lenses on successfully. And recently, more and more study have found that, spectacle, myopia control spectacle has been, in a commonplace, particularly in a lot of Asian country, they has been utilized, extensively. And, the outcome has been really fruitful. And so I'm not going to talk about that much because I know there's another lecture coming up for that. But really, again, present the option to the patient. There's something new technology out there, and we should be aware of that. Eventually, it will come to your door, and it will benefit for your patient in the long run. Another aspect I like to present is about the pharmaceutical perspective using the low-dose atropine. And generally speaking, the atropine use has been, pretty straightforward and intuitive for patient to understand. It's just a matter of eye drop. Patient doesn't have to do much, and so it's a low maintenance level of modality. But you do have to, be aware, what kind of potential adverse effect they may potentially foresee. Many patients may not even aware, they may have light sensitivity issue, or the people get a little more dilated, or simply having some sort of blurry vision up close initially. Depends on how long the adaptation period would be like. And I usually like to use atropine as not just my monotherapy, but also serves as a bridge or adjunct therapy, for my patient. Because a lot of time patients are scared or apprehensive about contact lenses wear. They don't know where to start. So I usually start with the eye drop for them to help them, get used to the tactile maneuver, get used to something touching the eye first before I actually present the option of using contact lenses in general. And interestingly enough, I found that a lot of patients, especially coming from a different cultural background, particularly a lot of my patients are actually coming from Southeast Asia and India. They actually believe that atropine is not part of a treatment, interestingly. Rather, they actually believe ortho K and also sort of contact lens modality is the way to go. So when it comes to, presenting to patient for different modality, you need to understand the cultural awareness and what they actually believe in. Otherwise you will probably spend a lot of time, and patient does not even understand, or appreciate what you're trying to tell them to do, because there's definitely like a cultural perception being ingrained in those particular patients. So just something to be aware of. So when it comes to the art of communication, many of you already understand what to present, but the challenge always, including myself, and I've always been, finding ways to perfect my conversation and my dialogue with the patient, how to support patient, and the parent, to better understand and prepare better future for their kids. I found it very interesting that interestingly, recently a number of article have been published. One of which is published in 2022. They found that a lot of parents actually have been struggling with their own identity. A lot of parents actually don't appreciate themselves as a good parent because of societal standard. And 30%, 36% of those parents actually feel like, being a parent has been somewhat harder compared to what they thought, parenting should be like. And as I mentioned earlier, cultural impact play a big role when it comes to conversation about myopia management. Different patient depends on different demographic, different culture, they see or perceive myopia differently. In one study, found that parent of color, particularly those are Asian parent, nearly 50% of those patients prefer raising a child somewhat differently compared to their own upbringing. What does it tell us? What it tells us is that, patient doesn't want their kid to follow their own footsteps. A lot of Asian parent or just in parent in general, they already been myopic when they're young. They really want to change the trajectory of how the kids are growing. So you really want to emphasize the fact that, this is not just about you as a parent, but also your child. The child play a big role when it comes to participating in the overall process, overall journey of myopia management. Just to switch gear and learn more about how each patient or each parent would behave. This is a really good resources for you to look into. This is one of the clinical psychologists. His name is Dr. Bromman. He actually coined the term Bromman parenting style. And based on the level of demand and based on the level of responsiveness to categorize different type of parent. So I think I encourage you to, next week, when you go back to clinic, see your patient and your parent and their parent, you definitely want to, kind of do a detective work and see what type of parenting style, are they presenting to you. And because of based on different parenting style, you can actually help identify what type of conversational skill you're going to use. So let's briefly go over these four different parental style. The first thing is about permissive style. These are the type of parent who seems to be child-driven. Everything is about the child. Sounds really good, right? So every time when I present to the patient with this type of permissive style, they will ask the child, "Okay, Johnny, what do you think? What do you think? Do you think you can really handle the lenses, or do you think you can really tolerate the eye drops?" Everything is about asking the child, yes or no. The parent itself themselves are not really play an active role in this conversation. It's all about how to respect the child perspectively. However, and this is something that could be hard, because for adult like us, it's hard to engage or disengage, what kind of response is truly reliable. Many kids actually cannot really differentiate between normal visions versus abnormal vision. So let alone, ask them to make a decision for themselves. It's really difficult for them to do so. So one thing that I found it helpful is that try to simplify the conversation and avoid all sorts of jargon. Instead of using myopia as a term to describe this condition, I would say, your eyeball is really getting longer, longer than I expected. And I want to, really make it healthy by keeping the same eyeball in the same size. So keep it really simple and avoid jargon. Have, the patient be part of it, make them feel important and be on a spotlight. That will actually generate a bit more attention and also the interest from a patient perspective as a child. Dealing with a different type of parental style is the uninvolved lifestyle. So these are the things that would be really incredibly challenging in my perspective, because this type of parent doesn't really care much about myopia or eye care in general. They will always ask me, okay, after all these conversation. Why do I need to care about myopia? Okay. How does it impact, my child? So in this case, either the parent nor the child feel like they're a decision maker. They don't want to be involved, or they simply don't feel interested, in this particular subject matter. And as a parent, it's really hard for them to understand. If they don't understand the subject matter, it is hard for them to provide guidance for their child. So one thing that I find it helpful is that, do something or say something that could actually catch the attention from the parent. No matter it's from a lifestyle perspective, or from any particular incident where you can draw your personal testimonial with the parent. I think that would really be catchy. And this time, instead of asking the patient to be the center spot, we want to make the parent to be, the center spot and make them feel important. Because if the parent doesn't really care enough, let alone the child cannot really appreciate or understand, what this conversation is all about. It's all about them, But if the parent doesn't really take an initiative, it's really hard to engage the conversation going forward. Going forward, this is a type of parent that I find it, is a love-hate situation. Those are the type of parent who presented to them with the authoritative style. The name sounds really, have a negative connotation, but in fact, those type of parent are actually coming in well prepared. They will present it to me that, oh, doc, I did my own research about myopia management, but I want to learn more about this specific treatment modality, A, B, or C. And these type of parent already come in pairs, so obviously they are the decision maker for the child, and they would show you that they're engaged, they're invested in this matter. You don't have to spend much more time convincing them to stay behind for this conversation, and they obviously will show you the nurturing role and be able to provide guidance for the child, and they will ask the child for their perspective, but not necessarily dominate the whole conversation. So one thing that I would keep in mind and find it helpful for this type of parents is that you really want to come prepared as a clinician as well. Be able to show and tell them what is out there, what myopia is, what the statistics are, just state a matter of fact. Keep the dialogue very simple and matter of fact, and make both parent and the child to be, have the same equal center spot, and make them feel special, make them feel this is the decision we have to make collectively. Otherwise, if you just focus on one specific aspect, ignoring the other party, it's really hard to, make them, understand collectively. Last but not least, it's about the parent who presented authoritarian style. Those are the parent who will present to you that, okay, I know my child the best. I really want this, to happen. I already know, the success rate of this particular treatment. I just want to know about what this measurement is about. Tell them everything, that you need to know. And by this type of presentation, you know that this type of parent are the sole clinical decision maker. They don't really have the child have any say. They're over invested and overbearing. Sometimes, the child feel being accused, for having myopia at first place, which I feel really bad and, not really good about, the child feeling that way. But one thing, as I mentioned earlier, is to keep it simple, keep it clean, and just to stay a matter of fact, and just to come prepared with a lot of statistics and chart, as a clinician, the BHVI, chart up there showing that, what myopia can do for your child by the time they're 30 years old. So, but this type of parent is really hard to engage. So you want to try to stay away from any sort of emotional attachment with them. They really want to just invest with data. All right. They are data-driven parent. So what we learn from this is that talking to parent may get the attention, but talking with parent using the specific parental style can actually make them feel special for the child. You really want to make them, feel connected and make the decision collectively. And for the sake of time, I will just briefly go over some of the challenges and how we can provide enough educational resources for you as a clinician. You also want to emphasize the fact that this journey as for myopia management is not a one-person journey. It's a collective effort, including clinician, the parent, and also the child to make a decision collectively. So you want to emphasize the fact that myopia is something that it will affect your child and also affect you as a parent because the child, if they grow up with myopia, chances are they will encourage a lot of obstacles and roadblock later in life. And one resource that I really emphasize is the review of myopia management, for which I have an honor to being an editor for that particular publication. So I'll be happy to share more resources if any of you are interested. When it comes to follow-up care, I usually focus on three different aspects, three different pillars, okay? The first is a consultation, showing the patient about what the data suggests about your myopia status and really establish good baseline expectation and be able to help build the relationship and rapport. Secondly, once you have the patient sign up or proceed with the treatment, you want to know how to track the progress clinically. You really know that myopia management is not something you can just do it from day one. It's a marathon. It's not a sprint. You really have to, do your work, be able to establish a good baseline reliably and focus on axial length is the absolute, metric for us to understand the physiological growth. Without knowing axial length, essentially you're just driving out blind without the headlight on. But one thing to keep in mind is that, axial length is one metric that we can rely on, but don't fall into the pitfall of having a rat disease. For those who are managing glaucoma, I think you understand what I'm talking about. By having the rat disease pitfall, it means that, every time when you see the OCT scan, you just based on what the color show you to diagnose the condition. So many of time, glaucoma doesn't present with any RNFL thinning. So that's a really key thing to understand from a perspective of myopia. Myopia may elicit a lot of different angle, different pictures for you to understand, not just about axial length. Axial length play a big role, but not the only metric that we should focus on. Last but not least is about how to present with good follow-up care, determine what works and what not, when to present monotherapy versus combination therapy, and what is the cadence of presenting follow-up. Usually I present it with 3, 6 months, and 12 months apart to engage with the overall progress. Briefly about, better eye health. It's not just about eyeglasses or any sort of modality for myopia management. It's also about what they eat, how they take care of the eye health, including exercising, including, what type of fruit and vegetable they're eating. Are they engaging with any sort of visual hygiene? Do they spend enough outdoor time? That type of question you should definitely engage with your patient as well. So to conclude, I want to focus on three different aspects. Action plan for you as a clinician. The first thing is to help them understand how the patient understand what myopia is about. It's about the key communication and present it early. Once you have the intervention presented early, you're able to manage it in a better effort and be able to help change the trajectory of the child's vision for the lifetime. And we also want to emphasize the fact that by providing parental support, help them understand what this journey go through. You have the obligation to help them, present in a very cohesive manner. As a clinician, I usually like, perfect, my what we call the elevator pitch, by, using 30-second elevator pitch. What can we say to the patient in a 30-second, to make them aware, make them feel important about the journey of myopia management. To conclude, I would like to have this quote to share with you all. It's from Dr. Nelson Mandela. He said that if you talk to a man in a language that he understands, that what goes to his head. But if you talk to him in his language, that what goes into the heart. So that really, pinpoint the fact that, it's not just about what we say to the parent, but also how to say it and in what way. That what goes to the heart. Thank you so much for your attention. I will be happy to answer some questions that you may have.
Thank you so much, Dr. Chan. I wish the presentation could go longer. There was so much to learn, especially when you talked about the parenting styles. So we'll dive right into the questions. I'll ask the first one and then we'll go to the chat section. So I can really relate to an example you gave about putting trial lenses in the eyes of a parent to understand. I did once have a parent, I think the kid was less than 10, but really high myopia. I think he was a -9 approximately, if I remember correctly. And at the time, we had put him on low-dose atropine and bifocal spectacles because that was what was available then. This was about 3 years back. We didn't have access to multifocals then or orthokeratology. However, the child had presented for follow-up not wearing the glasses anymore and had said the parents, his father, wanted him to stop wearing the glasses because he was becoming too dependent on the glasses. And I mean, my initial response was anger towards the parents because I was wondering how foolish can that be? But then I realized the parents don't really understand the way the child sees. Parents are metropic. The kid is a -9. To them, they just feel they don't understand the way he sees. And I understand from your perspective what you explained about having to try to frame them. And I mean, after the anger washed away, I did put a +9 lens in front of the father's eyes in trial frames. And I just asked him to walk around the clinic, and he nearly tripped a few times, so he understood. And surprisingly, he became teary. And I guess he understood what the child was facing. But this is the scenario that a lot of practitioners face in Africa. It's one thing for you to be able to diagnose the myopia, you recommend strategies, but yet sometimes parents just have that stone wall and are not interested in myopia management or even getting spectacles in the first place. What would you say would be the language we should use in order to first get parents to understand about myopia management and the need for myopia? Because it's very easy to resort to scare tactic to talk about, oh, there's a 10% chance you develop glaucoma or cataracts or retinal detachment or maculopathy, because maybe you feel if you scare the parents enough, they might take it serious. But I have seen that to be counterproductive as well. So what would you recommend would be the starting strategy for us to talk to parents to be more receptive towards myopia management?
Sure. Yeah. So that's a great question. And I typically would start with the mindset that, it's not about what we say or talk about as a clinician. It's actually help learn from the patient and the parent as well. I usually start with asking them, okay, Mrs. Jones, can you help me understand, what you learned about myopia at first place? What do you know about myopia? And what can we do to help your child? If you start with this conversation by the question, I think they would usually, feel appreciative and also be able to, tell you more about their child's story. Because I think a lot of time parent has have a stone-faced wall or just have a wall in front of you is because they don't trust the clinician. They don't feel like this is necessary for us to share with the clinician. So I think by breaking down the obstacle is by letting them be the initiator, be able to help them take an active role, share with you, about what they know about their child's myopia or their eyesight in general. They may not even aware the child had myopia first place, but help them take the lead and you as a clinician be a active listener. I usually just make note. I usually barely say anything at the beginning. So, but I think by asking the question in the first place, it opened up door about what they can say to you for your child.
All right, thank you so much for that. So I'll take one question from the chat section. Um, how can parents distinguish between normal screen-related eye strain and early symptoms of myopia or early signs of myopia?
So the question is about how does parent differentiate
How would
between
you say
screen time?
parents should be able to differentiate between the signs of just eye strain from using screens too much or when this too much screen time is associated with myopia, what would you say would be the things parents should look out for in terms of viewing behavior in their children with myopia?
Yeah, so I think it tied back to the first presentation by Dr. Levi about like the mental health aspect, related to myopia. Because a lot of patients, anecdotally, we found that patients who have screen time or eye strain due to screen time, is just a matter of they don't have enough time for taking breaks or lack of outdoor time. But it's one thing that they have experienced some eye strain, but it's another thing that, if the child start having some, behavior agitation, or they cannot really, spend enough time, engaging in one specific topic, that is something that is tied back to the mental health aspect. Maybe we do need to do a better job to educate the patient that, screen time can directly relate to the mental health. If you let your child spend too much time on a screen as if this screen time is a pacifier for them. You as a parent may not know enough, okay, about how to parent your child for better eye health. So it's not about making accusation, but just to let them feel aware that screen time can have direct impact to mental health. If the child presented to me with some sort of ADHD spectrum, or they just cannot have enough attention span with me, then I know that, this patient may have excess screen time without any supervision.
All right, thank you very much for that. And I'll just add to that by saying sometimes it may not even be the screen. Personally, I found just having a conversation with the patient, the child itself, and understanding their behaviors in certain environments. For example, the parents might come in and tell you the teacher said there's something wrong with his vision. But when you speak with the child, they may not be able to express because, as you said, they probably just think that's the way everybody sees. But you may want to ask certain questions about their viewing behavior, like, do you often require help from your friends or your colleagues in school to maybe copy something from the board?
Mhm.
Do you have to move closer to the board? Those kind of things would give you cues. And it's also something that, I mean, probably Levi would have been able to speak more to this, but it's something that once we get parents involved and that aspect of the shame or guilt that they
Yeah.
feel, sometimes once they realize that, oh, they should have asked these questions or should have picked up the myopia in the first place. I think as clinicians, we should also be involved in alleviating those fears and anxiety that they experience once we've um, diagnosed the condition and realized that the child actually has this problem. Someone left a comment in the section asking if the slides can be shared. Actually, this is recorded, so the recordings will be posted on the iAfrica Media YouTube page, so you can go back and rewatch it. The slides are the intellectual properties of the speakers, but they can choose to share it personally with you if they choose to do so. Um, I'll take another question, which says, how can schools collaborate with parents to support children's visual health, especially prolonged classroom and homework screen exposure? So, from your perspective, what would you say we can do to get schools more involved and parents more involved with getting kids to spend more time outdoors, less time on digital devices?
Yeah, so that's a good point. Because as you know, a lot of daily schoolwork has been dominated by screen time, computer work, and it's just something that we haven't encountered in the past 2 decades. When I was in school, I never have a computer in my school. So I learned from blackboard or chalkboard. But I think at this point, many patients are experiencing that, peer pressure about learning stuff online, social media stuff. So I think, one thing that we have tried previously to engage with pediatrician or school nurse with the patient is that we present to them with a um, parent workshop, in school, just to show them, show and tell, very simple about what the eye is about, how myopia can affect the eye structurally and, long-term wise, and do some free screening for the school children. That will actually help them initiate that, spark the interest about, oh, there's more to do with just like a pair of glasses. So I think providing free vision screening, talk to them, from a parental workshop, and be able to provide like even like clinical resources for school nurse, maybe like a one piece of information sheet for them to understand how to screen the patient, not just about pass or fail, but be able to not to make a diagnosis because it's our job, our scope, but have the school nurse be able to tell, what does -2 means to them. Because a lot of time, even a pediatrician may not be able to understand what a -2 myopia means to the child. So they would just say, oh, you pass or fail. But it's not good enough for us to understand, how how it get impact to their eye health.
All right, thank you very much for that. So my next, so I'll take one comment from the section and then I'll ask my next question. So, this comment says, I'm a very high myope and I can relate to these presentations. So my next question is, I mean, we're both contact lens guys, Kevin. So my
Yeah.
specialty is cornea contact lens, you into cornea contact lens as well, and a lot of orthokeratology.
Mhm.
And I think in terms of perception and parental acceptance about contact lenses, it's probably better in the US than it is in Africa. Although currently I have more kids wearing multifocal contact lenses than adults, which is quite interesting. But
Mhm.
there's still that hesitation. I mean, I know how I present, but I would ask you this question. How would you present contact lenses as an option to a parent for myopia management who probably never worn contact lenses before and just seen maybe bad reviews online or regarding safety and things like that? How would you present contact lens options to patient and parents for myopia management?
Yeah, that's a good question. And contact lens is not something we can do, as I mentioned earlier. Even a child as young as 5 or 6 years old, they can easily, not easily, but they can manage to wear contact lenses independently. But depends on the child specifically. It's not one size fit all approach. You really have to learn from the child and from a parent perspective what is the best way to engage interest and motivation to your child. And contact lens is not just about, okay, providing, the training protocol A to Z. It's not as simple as that. You really have to engage from not just about the cognitive perspective, but also the behavioral perspective. Because a lot of parents, feel so overbearing. Some patients are just, they are breathing over my shoulder, when I talk about contact lens INR. It's really hard to engage with a child when the parents are around. And believe it or not, it's actually easier, if you work with the patient independently, one-on-one, instead of having so many different people around. It creates a lot of social pressure. The patient cannot really, feel comfortable, exuding themselves. So I think the question is about, just the percent contact lenses is nothing to be scared of. And it's just one of the medical devices that has been shown to be safe and effective. And I even let the child play with the soft contact lenses in the first place. If they found very apprehensive about touching, I asked them, okay, take a look at the lenses. It looked like a jelly to you. Is it like jelly bean? Then have them get a feel of the lenses so that they don't feel apprehensive going forward. Just like the same thing when I present to patient about atropine drops, same thing. I present a little water drop or lubricant solution onto the fingertip to let them have a first-hand experience about what the drop would do for you. If you don't feel anything on the fingertip, there should be nothing on your eyes too. So have them, get a first experience and be able to overcome that mental obstacles. I think that's the key. By just showing them, it will easily save a lot of your effort talking about the nuances of contact lenses because it's so overwhelming for them. Just to get them, feel and learn about the lenses, I think it's a really critical, very simple but critical step for them.
Yeah, thank you for that. And I think one important point you made about sometimes speaking directly to the patient and treating the patient as an individual, especially when they're kids, because sometimes we think they probably would not understand what you're talking about. But when you use those simple terms and you're speaking directly to them, it helps. Another very important point you made was about sometimes having the kid, just you and the kid alone in the room, especially when you're doing the insertion and removal training, because sometimes you might have the parents scolding them at the corner, no, you should do this, put it in. But as soon as the parents step out, they insert the lenses easily and you wonder the pressure was coming from the parents. So I think those are very important points. Thank you very much for that. I'll take another question. So this question says, it is said that there is no safe level of myopia. Therefore, myopia management or control should start with patients as low as minus zero point 0.5. What's your opinion on this? I mean, again, there's no safe level of myopia. Is there any particular level you would want to start managing, or you start managing right off the bat from diagnosis of minus zero point 0.5? What's your opinion?
Yeah, that's a good question. And I encounter this a lot, when I interact with other clinicians. And I think you have to put the minus zero point 0.5 or low myopia in different context, because having a zero point 0.5 diopter myopia doesn't mean anything to the patient or even to me, because having a 6-year-old with a minus zero point 0.5 diopter is the different one. It's coming from a 12-year-old minus zero point 0.5, because the risk of developing long-term axial elongation from a 6-year-old is actually a lot higher than someone who are developing this condition from a 12-year-old. So you have to put that into context. But to put that, into this perspective, I would say, in my personal opinion and my clinical experience, I found that if you treat someone at as little as minus zero point 0.5 diopter, the outcome would actually be much more outstanding than treating someone at a minus 4. Even though from a parental perspective, they may have a hard time understanding why do I need to treat someone as little as, minus zero point 0.5. But, once you develop or diagnose this condition at a low level, they would just accelerate very quickly, like a train wreck, especially for those who are younger than 7 years old. And you have to understand from a spectrum of ametropization. If someone presented to you at 6-year-old with a minus 50, they're not going the right direction. Rather, they should have been, at a low hyperopic state. But they're just crossing the line already. They're no longer be able to stay hyperopic. Rather, they are myopic at a minus zero point 0.5 level. So put that into perspective instead of just focusing on the absolute refractive error, and also put into context of what is the age of onset of low myo, and that will actually put, patient in a different perspective of how you look at myopia at first place.
Yeah, thank you very much for that. I mean, I think it's important to establish a risk profile for each of these patients. Like you rightly said, minus zero point 0.5 in a 6-year-old and minus zero point 0.5 in a 12-year-old. Those are like different scenarios, and you probably would want be more aggressive with the younger patients, looking at the risk of other complications. Um, Now, my last question, before we call it a day would be, um, you did mention towards the end of your presentation about diet. Again, we look at that in terms of lifestyle as well. We talk a lot about screen time, we talk a lot about outdoor time. I did go through a paper maybe early this year or late last year in a journal club group I belong to, where we had presented the impact of gut microbiome and myopia. And they had actually looked at in the younger children who were being fed more ultra-processed foods seemed to have more myopia, more progressive myopia compared to those who had eaten more natural foods in rural areas. And do you think we should start looking at recommending dietary modifications, or maybe begin to ask the questions? So maybe we might have data in future. Do you think there's something there to look at? Is that something we should be talking to parents about?
Yeah, that's a good point. In fact, in my clinical practice, I have a questionnaire for them to fill out, just like dry eye questionnaire. And I ask them, what kind of lifestyle you engage in, what kind of food do you like the most? Many patients obviously say candy, candy is my favorite food. And then vegetable is the least favorite, right? So, but to be specific, I want to learn more about what kind of food they are interested in most, because as you said, I agree. Ultra processing food have definitely have a lot of negative impact, not just about the health, but eye health as well, because it create a lot of oxidative stress for the eye, And one thing that myopia doesn't like, is the acceleration of oxidative stress. Whenever you have that type of oxidative stress rising up, you are actually going to impact, the retina in a really different level. We don't even know how far we can go. But yeah, so I do agree that, by engaging with different question in the questionnaire or simply engage with a conversation with a patient and parent about, are you a picky eater? What is your favorite food? And again, depends on different demographic and cultural background they're coming from. A lot of patients, especially they are from Southeast India, they have a lot of like spicy food, a lot of like herb, so these are the things that have not been explored, in the literature. So I'll be curious to find out, how much of the when food intake or nutrition in general would impact, the developed myopia. But to your point, I also read another paper recently is about blueberry. Blueberry have a really high
Absolutely.
the radical, like it can help eliminate the radical
Yeah.
oxidative stress. It will
Mhm.
actually help mitigating the development of myopia.
Yeah. Thank you very much for that. There was a follow-up question to the minus point 0.5 question. So I'll just throw that in the answer as well. So she's asking, or the person is asking rather, what if this was a minus 0.25? I think we would consider that pre-myopia, and then at this point you have to look at risk factors. I mean, there's also evidence that you can manage pre-myopia with lifestyle modifications, more time outdoors, less screen time. There's even evidence for the use of low-dose atropine and even the difficult spectacle options as well. So again, I think it boils down to looking at the risk factors. Just the same way you would not look at a clinical picture and make a full diagnosis or full treatment plan, there are certain other confounding factors or other things that you would consider. So, I mean, looking at the risk profile, I would say is more important than just looking at the number to start your management. So, do you have any other thing to add, Dr. Kevin?
Yeah, I totally agree with your perspective. We as a clinician, we need to understand myopia as a multifactorial condition. And it's safe to say that it's a disease that we need to all manage and be able to equip, how to manage it in a really holistic manner. Because if you just simply focus on the refractive aspect, myopia would never be able to help manage well. So you need to change your mindset and your perspective about how we treat myopia at first place. Otherwise, you will never be able to, caught up with the momentum.
All right, thank you for that. There was a follow-up question to the study I had mentioned about gut microbiome. Yeah, they considered other confounding variables, but what they had actually done in the study was to look at the they took stool samples and looked at the stool samples in the myopic versus the non-myopic group, and then tried to relate that to their diet. But there were other factors like their age, family history of myopia that was taken into cognizance as well. Would not dwell so much on that. I mean, I think we've gone quite far today, and we would want to keep you. I know it's quite late in the day for you, Kevin, but thank you so much for joining us today. If you have further questions, you can send us an email, and I'll be happy to direct it to Dr. Kevin and get you answers. Also, the recordings for this will be available on the iAfrica Media page, YouTube page. So you could go back, rewatch this, especially for those of you who are asking questions about the parenting styles we have talked about and how to apply that in clinical practice. I think that's something that's interesting. And by the way, I think that's something that probably should be studied. The way we have studies that have looked at the way you present contact lenses to patients and how many of them purchase contact lenses later. Maybe we might have studies that explore presenting myopia management to parents in different styles and see which works best. I think that'd be an interesting study to look at. Thank you so much, Dr.
Very
Kevin.
cool idea. Yes. Thanks for having me. Thanks for everyone for joining this webinar. I hope you enjoy the rest of the week, with a lot of like interesting and impactful talk. I look forward to, come back and share one more with you.
Thank you so much. And you can catch Dr. Kevin's articles or opinions on the review of myopia management. There's a lot
Mhm.
of resource there that can help you in clinical practice. I've also shared a link to the impact of myopia on parental mental health that's published on the iAfrica Media page as well. You can read through that. Dr. Levi, before he left, had dropped some questionnaires that you can use in your clinical practice for your patients as well. So thank you all for joining. We'll see you tomorrow. Use the same link for joining the meeting tomorrow. Thank you all. Good night.
Thank you so much. Good night.
Yeah.